All right, good afternoon. Good afternoon, everyone. My name is Michelle Galdámez. I am Senior Health Policy Advisor to Congresswoman Robin Kelly. Thank you so much for joining us during this session, Advancing Policy-Driven Solutions to Address Barriers to HIV Prevention Access. Right here on stage, I have three distinguished panelists, all coming from different sectors, but all with one goal, which is to mitigate some of these barriers to HIV prevention access, but also inform and educate the populations. First, I'd like to say a quick facts to level set before I go on to introducing our amazing panelists. And to paint the picture on HIV, globally, there are about 39.9 million people living with HIV. And out of those, 53 were actually women and girls. Here in the US, it's 1.2 million people that have HIV. So what has Congress done around this topic? Well, we've had great legacies like Rep. Barbara Lee's, who have, she has definitely paved the way, whether it's been globally or domestically. And she actually passed that torch to my current boss, Rep. Robin Kelly, just last Congress, to lead the charge in reauthorizing PEPFAR. Well, I know these three distinguished gentlemen definitely have heard of HIV, PEPFAR, and the barriers that our communities experience. So first off, I'd like to introduce Christian Morris at the end over here of our panel. Christian Morris is completing his master's in public health with a focus in health behavior this spring from UAB. He currently works full-time as a research coordinator at Us Helping Us, a historically Black nonprofit working to reduce the burden of HIV on the Black community in the Washington, D.C. metro area. Christian is originally from New Orleans, Louisiana, and has a passion for addressing intersectional stigma and advocating for communities' right to life and mental health. Thank you, Christian, for joining us.
Thank you.
Then we have Dr. Keith Rawlings. He is a former senior medical director of medical affairs at ViiV Healthcare. Prior to joining ViiV, Dr. Rawlings served as director of HIV medical sciences at Gilead Sciences. He is past chair of internal medicine and co-chair of the infectious disease, HIV, for the National Medical Association. He has published over 100 abstracts and manuscripts and co-edited one of the few books, HIV/AIDS in the US communities of color, on the HIV epidemic among minorities in the US. Thank you, Dr. Rawlings, for joining us. Last but not least, I have Carl Schmid to my right. He has been a national policy and advocacy leader in the HIV community for over 25 years. In December 2019, he formed the HIV plus Hepatitis Policy Institute, which promotes quality and affordable healthcare for people living with or at risk of HIV, hepatitis, and other serious and chronic health conditions. He spent 16 years with the AIDS Institute, serving as its deputy executive director. He's a cancer survivor and living with chronic hepatitis B. Mr. Schmid earned a BA in the public affairs and an MBA in international affairs from the George Washington University here in Washington, D.C. Thank you, Carl, for joining us. Now, as we saw in the amazing introductory videos, it is about having focused partners and partnership across policy, research, community, and focused partners like Gilead and others in the space to make this all happen. Just like with policy, you need your state, your local, and the federal government. But I think for the purpose of this conversation, it's important that we level set the knowledge in general for our audience. So I'm gonna start off today's discussion with this question for all my panelists. Could each of you briefly describe the primary barriers you see to HIV prevention access and better support the PrEP use in your respective areas of expertise? So whether it's research, clinical care, or policy, and how are these barriers impacting individuals and communities most at risk? Why don't we start with Chris?
Okay, awesome. Hi, everyone. So my first thought to this question is that it's not a one size fits all, and you have to think like population specific, as I'm sure we all know. So the primary barriers that prevent, let's say, heterosexual black men versus LGBTQ youth versus black women is going to be different for each population. And so in some of the PrEP outreach work that we do at SWS, we do try and cater it to the specific population. So I would just say, in my personal experience, I feel like stigma is really a big barrier, particularly for heterosexual black men. I would say marketing for PrEP for black women. Every time I have a conversation with a black woman about PrEP, the response is the same. I didn't know that was, for women. All the commercials, I don't see myself represented in those commercials. And then for LGBTQ youth, I really would feel like just low perceived risk. That's really, from my experience, testing people, like I'm on the front lines, I didn't take it, I'm not sexually active right now, but we know it only takes one time. So I think it just really depends on which population you're trying to target and understand.
Oh, that's great. Dr. Rawlings?
So I'm going to take a slightly different approach. I'm going to say the primary barrier to PrEP are actually healthcare providers. I'm just going to start there. And the reason I say that is because for whatever reason, a lot of us believe that the age that you're supposed to stop having sex is whatever age your parents are or what they were. And I say that because we have gotten into a habit of pretending that PrEP is all about your behavior. And I would contend that we increasingly now know that this is almost as important to be your geography. Where you live, where you reside is actually the better teller of whether or not you will actually acquire HIV in the United States, because half of the people that acquire every year can be identified with roughly 48 counties, 3 cities, and 7 states. That's it. And while we like to talk about who is having sex with who and how often and whatever by healthcare providers, I would contend that the bigger problem is that we are using that as not so much as an access, but as a barrier to healthcare. If you are a woman and you went to your doctor and they never did a pap smear, you would not keep going to them. You would not keep advising your friends to go to them. But why do we go? The pap smear is just literally a screen for a viral infection that's mostly related to sexually transmission, leading to cervical cancer. HIV for PrEP is a viral infection screening that looks for the same kind of process that we just don't pretend, or we pretend that everybody that we talk to, we can somehow look at and pretend who they are. And while I agree with you that there's a certain amount of this about what we see in the advertising and so forth, you will not get on pre-exposure prophylaxis unless you see someone who can write a prescription for you. Those two things go together. And I would literally say that we need to begin to think about this less about what is your behavior or the demographics. The demographics overlay this, but if you live in one of these places, everybody in that particular geography should be getting tested. Stop asking people who they sleep with or how many people they sleep with. Just simply test them in that context, because only people who are tested negative get on prevention. The people who test positive, we want to get into treatment. And if we're talking about PrEP, we need to begin to differentiate those two things.
So I feel that the biggest barrier right now is the lack of political will and leadership. It's wonderful that we have the drugs, both for treatment and prevention. And, but HIV is a public health issue. It's an infectious disease. That's the role of our government, both federal government and state governments and local, to deal with these issues. And, we have a CDC, we have an HIV program there, we have an Ending the HIV Epidemic initiative that President Trump started in his first term. And, it provided a focus on HIV in the United States that we hadn't seen in a while. But it takes sustained funding. It takes sustained leadership. And you need education. This has to be on people's minds. It has to be, yes, it's great to have the ads, But we need the local governments, and it was great to see that Baton Rouge work being done. But we need that in all the jurisdictions. We need the buy-in from leaders, your elected officials. Unfortunately, a lot of conservative, representatives don't get involved in HIV issues. But I think that is the biggest barrier, not getting to the communities that need it most. I agree with Keith, we need provider education too. So it's not only community education, it's provider education as well. Unfortunately, we're seeing an erosion of CDC's power, influence, funding right now. We could talk more about that right now in this program.
Absolutely. And yes, I hope we get to talk about that. What a time to have this conversation and just this convening as well, thanks to NMQF. Dr. Rawlings, you definitely brought up a good point that I think we should segue, which is the healthcare providers and how we know there's a work shortage, but even just a workforce shortage. But given the evolving landscape or HIV transmission rates and the growing understanding of geographic factors that contribute to increased risks, there has been some discussion around whether current testing recommendations adequately reflect these regional variations that we're seeing. So do you believe the CDC testing recommendations should be updated to include geographic location as an indication for annual testing? And caveat is the CDC still stands to do that.
Yes. So the short answer to that is yes, I do. Right now, the CDC recommendation is that anyone between the ages of 15 and 64 should have at least once in their lifetime an HIV test, which is fascinating as long as you believe that people behave the same way that they did at 25, at 55, and the people who do things at 30 are the same at 60, which is clearly not true. The other part of this is that, as Michelle has mentioned, we have been seeing a steady decline in the HIV treatment workforce for the last decade and a half, and COVID exacerbated that. The only major infectious disease pandemic in the United States before COVID for a long time was HIV, and many of those providers are either retired, they have moved on, or they have been adversely impacted by the decreasing in the funding in academic institutions that used to support their jobs and their engagements. I will point out, though, that I say this about the healthcare provider because while there is indeed an important role for the federal government around HIV treatment, which is the Ryan White Care Act, which by the way, is the most successful thing in infectious diseases in the last 30 years, where we have been able to go from learning about an epidemic, a new disease state, and then getting interventions to improve. And it is the only thing in the US health system that has shown that you can pretty much mitigate the racial and sexual disparities that we've been seeing in HIV, has been those people who have been getting exactly the population that everybody claims they can't find, that won't come to care, that doesn't have insurance, but is the most successful group to actually suppress the virus in the country. The reason why this is important about PrEP, however, is that Ryan White doesn't cover prevention. It is not part of the federal funding. There is no federal funding that I'm aware of that's specifically aimed at HIV prevention. It's all aimed at treatment. So if you're HIV negative, you don't get the same resources as if you were HIV positive. While there are recommendations within our, for the US Prevention Task Force, it is also, as Michelle mentioned, this is a behavior that goes on also at the state level. We have had states who have literally sent back CDC money because they didn't like the population that we were engaging, even though their particular state was one of the ones that was most impacted by new cases. If you're going to address that, I agree that we need to do something from a policy standpoint, but the reason why I'm suggesting that, to Michelle's question, that they engage geography is that if you only say that you are going to test this person once ever, it would make more sense to not pretend that their behavior is something, and rephrase this, and you don't talk about what their sexual activity is. The last time most of you went to a healthcare provider, they never asked you who you were having sex with, how much sex you were having, or anything else. I also find it interesting that healthcare providers that give out prescriptions for erectile dysfunction drugs don't want to talk about sex. So, which is kind of defeats the purpose of why you gave them the drug in a certain level. But the other part of this is that HIV is not just a disease of young people. 50% of the people living with HIV in the United States are now over the age of 50. By 2030, we anticipate that will be 70% of the population. We have to stop pretending that we are going to be able to pigeonhole people either by age or by race or by their sexual activity and begin to engage them about making this part of a routine form of primary preventive care. And to do that, the recommendation about geography is that instead of saying only within this age group, which the second line in that in the current statement is, if you have some other reason to test more frequently, the argument here is to be more explicit about the idea of geography. If you live in one of those states, in one of those cities, in one of those counties, which, by the way, came out of the Trump administration the first time. This isn't something that was there. They created this model that has been incredibly engaging about understanding, but we need to incorporate that. And I think that that manifestation, along with adding it to the U.S. Prevention Task Force, would be the two places that I think, from a policy standpoint, you could begin to influence this. Because that would influence what insurance companies do, what states do in terms of their funding, how Medicare, and increasingly, for those of you who do not understand, if 70% of the population living with HIV is going to be over the age of 50 in 2030, a bunch of them will now be in Medicare. And so I think that those policies and those kinds of things, particularly around the geography, have got to become a part of our discussion if we're ever going to get a handle on actually preventing disease, not just taking care of those people who are living with it.
That's very interesting, and I for sure want to segue into one of your topics, which was coverage. You talked about that, and Carl, you have focused a lot of your work on ensuring private insurance cover prescription drugs, including preventive medications such as PrEP. How are insurance currently complying with the requirement to cover PrEP without cost sharing?
Yeah, so one of the benefits of the Affordable Care Act, and this is for people who have private insurance, is that preventive services, grade A and B recommended services from the U.S. Preventive Service Task Force are, private insurers must cover them and zero cost sharing to the patient. Excuse me. So that includes a number, I think there's around 50 different preventive services, but for today's conversation, HIV testing, hepatitis testing, and PrEP are covered. They all have a grade A from the U.S. Preventive Service Task Force, and therefore insurers should be covering these services without cost sharing. So in terms of PrEP, it's also, it's important to understand that it's not just the drug. It is, you need a provider visit first to, make sure you have an HIV test. You have to be test negative to be on PrEP. And so you need a prescription, you need a provider for that, you need a lab test as well. And so we want to make sure that not only the drug is covered, but all those associated services as well. And what we found is that even though it is the requirement, a lot of insurers are not living up to that requirement. The CDC did a study that found around 1/3 of all the insurers are still charging people for the labs. And you heard this a lot when colonoscopies got approved as well, that people were still being charged, not only for their colonoscopy, but for the anesthesia that was associated with it, or the provider visits as well. And then there was another study that was conducted that it showed around 1/3 of the people are being charged for their drugs, cost sharing. And this is a real deterrent. When people are being charged, they don't, They don't show up to their appointments. They don't pick up their drugs. So, and the interesting thing about this other study was that even for generic PrEP, the insurers were charging people for their drugs as well. So we need enforcement. It's great to have great policy, great laws and regulations, and we do have a very good regulation out of the federal government that said that all the current preventive drugs have to be covered without cost sharing and without prior authorization as well. But again, that hasn't been fully enforced. And then we have to make sure that the new PrEP drugs are also included in that.
Absolutely.
Can I just add to that?
Yeah.
If you get a test, for example, in January, and it's negative, but now you engage in behavior that may do something that you now are worried about it, in some cases, the insurance companies will not pay for the second drug test. Not drug test, the second HIV test. It's not just can you get it, it is do you need it and can you get it when you need it. The testing is the key. You do not go into PrEP unless you are HIV negative, and you need to get a test in order to prove that. So we need to stop pretending that if we just do the test once, that somehow covers you for the entirety of the year. This is not a flu shot. This is a blood test or a lab test to determine whether or not you have now been exposed to a virus. You have to do it in that context, and many people may start off with, I don't need this now, but I may need it later. And I think that's the concern that some of us have about how the policy needs to be amended, to Carl's point here.
Absolutely, and I love how we've covered coverage, one pillar, a second pillar of just treatment, care, but a third pillar that it's worthy of mentioning is the community engagement, the trusted messengers, and that's where Christian and your organization definitely come in. You work with the Us Helping Us organization, which is based here in DC, so it gives you a frontline opportunity to directly help our community, this community. Can you discuss the community engagement work you've done to support access to PrEP services? And what are some of those barriers to access, especially in communities with low PrEP uptake?
Yes, thank you. So I want to start by just highlighting a project that we have called Community-Based PrEP, or CB PrEP is what we call it around the office. It's actually funded by the DC CFAR, which is the Center for AIDS Research, the coalition of Howard University, Whitman Walker, Us Helping Us, about 9 institutions here in DC who collaborate for HIV prevention and treatment research. So CB PrEP, 2 phases to this research study. In the first phase, we conducted just a series of in-depth interviews with PrEP eligible people to gauge and build out the design for PrEP initiations on a mobile clinic. So a lot of times, you know, when we talk about different barriers, not just providers, but we're talking about people having to come in to see a provider, come into a brick and mortar clinic, and there's just, I mean, a slew of barriers that can prevent someone from getting into a clinic. So we wanted to design an intervention in which we bring PrEP to people in community on a mobile clinic. So phase 1 was just interviewing people, again, PrEP eligible folks, Black folks here in DC, to see where should we go, where should this mobile unit be parked, who should be staffed on it, what time should it be, where, just sort of getting some community input in that. So that was phase 1, and now we're actually in phase 2, which is actually enrollment. So we're taking the mobile unit. I drive, you know, I'm safe, I promise. It's a big, you know, it's a mobile clinic, but we just drive it around Washington, D.C. in hotspot areas. So we sort of overlaid the hotspots that were identified in the interviews with what we know, to your point about geography, the zip codes with a high HIV prevalence rate in D.C. and PG County. And so we just overlap those areas, and we bring PrEP to people. So, you know, a lot of times it's a lot of PrEP education, right? People may not be ready to you know, a lot of times that interaction is folks' first time hearing about PrEP, because we're really in community-based settings, you know, we're not, you know. So that education piece happens there, but then we actually are enrolling people. They're like, actually, now that you explain it and describe it, I think that would be a great fit for me. And so Yeah, basically, so we just start folks off with a 7-day starter pack. We do the phlebotomy on the mobile unit, extensive counseling about PrEP and adherence and things like that, and people walk away with a PrEP prescription. So that's something that we're doing right now.
Thank you. And I hope the audience is also continuing to hear this theme of comprehensive care, holistic care, meeting folks where they are, right? And I want to get you on the spot, Dr. Rawlings, and your thoughts on how to, as we continue to confront the challenges of providing comprehensive HIV prevention and care, especially under this current administration. One significant issue is the shrinking size of the HIV workforce, which you already alluded to that already. What strategies or recommendations do you have for expanding access to HIV services in these communities, and how can we address the workforce shortage in a way that meets those needs?
So I think we expand the workforce by stop pretending that only a handful of people do HIV prevention. A handful of people do HIV treatment, because there's some complexity, there's some nuances that go along with that. But from a prevention standpoint, there's several strategies that we have seen. Some of those have been community-based, like mobile programming. Some of the ones that I can refer to that have been incredibly successful has been pharmacy-based, as opposed to having to come into a medical facility. Everybody goes to the pharmacist. They will spend time there, shop there, in other kind of ways, providing PrEP in those kind of contexts. Student health programs have become another place. If I get one more person who tried to pretend to me that, well, the people who go to college, they don't engage in behavior that puts them at risk for HIV. I want to know, how long ago did you go to college? But the other part of this is that this is an issue that is now becoming important across every discipline in medicine. And I say this because we're doing an initiative, for example, now within the National Medical Association, in which we're talking about HIV, both treatment and prevention, not just for primary care providers or infectious disease docs, but cardiologists, urologists, those ED drugs, I remember again. I mean, so if you're going to write a prescription for an ED drug, why is it you're not talking about PrEP? Obstetrician gynecologists, pediatricians, because pediatricians, we like to think of them as seeing only young, very, very young people. Many pediatricians see patients up into their 20s. In mental health facilities, the location is becoming less of the issue around the question of, are you getting a test in order to identify that you are negative, not positive, for whether or not it would be beneficial for you to get pre-exposure prophylaxis. The other part of that, I think, is that we have to begin to realize that the healthcare workforce issue is driven by the fact that we have made HIV care this sort of, it's not my problem. I'm going to send you to someplace else. I don't need to address you because I don't do HIV. I have had literally physicians, nurses, administrators who say things like, well, it is HIV prevention, I don't do HIV. I'm like, good, this person doesn't have HIV. They're negative and we're trying to keep them that way. The one big concern that I have in terms of the workforce is something that this administration is doing that I think is going to be particularly detrimental. HIV is, right now, we see people living longer because we're managing to keep their virus under control for the people who are living with HIV. And in many ways, they're living long enough to have all the problems of being old. They're starting to have everything that happens as you start getting into your 50s, 60s, and 70s in terms of healthcare. But one of the problems is that if we interrupt treatment, which this administration is doing things that may indeed do that, there's a distinct possibility that the people who are currently having their virus controlled will lose that control to do what we refer to as to stop being non-detectable, which means their virus is so low that we can't find it and they don't transmit. The real concern for me is that if we do this on a scale that now we have a substantially larger number of people living with HIV in the US than we did in the 90s and the 80s, that as those people, if they lose viral control, they will be able to transmit, but there's also the high likelihood that these population may become resistant to the drugs that they're currently on. Their virus will become resistant, which creates an entirely separate public health problem. that we do not have the personnel, the expertise, or the manpower in order to begin to address. So this is a twofold process. We don't have enough people to do treatment now. We do not have them geographically dispersed in the way that the epidemic is. And we have the likelihood that given some of the current policy decisions that are being made, that we may interrupt the success of HIV treatment, which will exacerbate the problem of HIV prevention. And so those two things go together to me as to why this is important, why this is particularly an issue for those of you who are engaged in policy, because you don't want to be that state. You don't want to be that particular institution where you're now seeing those individuals that used to be controlled, who are suddenly uncontrolled, able to transmit, and theoretically also likely to develop viral resistance in a virus that we do not have drugs to manage this for.
Can I add something on the workforce? I'm not going to disagree with you, Keith, about the need to normalize, HIV treatment and prevention. But, and you were right that we don't have we have the Ryan White program that focuses on treatment, and we don't have the corresponding program that focuses on prevention. But there is no barrier for a HIV clinic or a Ryan White clinic to do the HIV prevention work. They just can't do it with Ryan White funding. But most of them also are community health centers. But I feel that the Ryan White clinics are the perfect place to do HIV prevention work. They are geographically centered in the areas where HIV already is, and they have the expertise. They have hopefully they're a welcoming environment to the community. So they are perfect. We do need more funding so they can do that work. Also, community health centers, I think, are a perfect place to do more HIV prevention and treatment work.
And I agree with you, Carl. My argument here is that I'll just let the audience tell me. How many of you have ever gone to a health department to get anything done? Raise your hand. Not that you work there for your medical care. How many of you have ever gone to do that? The vast majority of the population never goes to these places. You go to your private doctor or whoever you're seeing in terms of your health care. What I'm advocating for is that, yes, Ryan White is great for those people who need the treatment. I was a Ryan White provider since its inception. But what we need to do now is to get to the population that is never going to go there. They're not that they don't have access to healthcare, it's the healthcare they have access to isn't talking about this as an issue. And if you take away the stigma of I'm accusing you of something, or I'm saying something about you, or I'm attempting to make some social or other kind of demonstrative statement about if I ask you for an HIV test, the easier way to me is to simply say, you live here. The only reason I'm testing everybody who's in my practice in this geography because of this data. And since this is no longer requiring the expertise of all the things that we've known about HIV treatment, stop pretending from a healthcare provider standpoint that you identifying somebody who needs prevention is as complicated as somebody who needs treatment, which is the reason why people don't go to Ryan White clinics if they're negative, because only people who go to Ryan White clinics are HIV positive. Even if you're at FQHC, sometimes that skews how that gets approached. So this is to deal with the policy aspect of this, to say, if you can get healthcare providers across the board. So in the NMA, we're trying to get oncologists, OBGYNs, cardiologists, respiratory, GI, to just simply say, if I take care of you, I want to make sure, and I live in this particular area, I magnify and dramatically increase the workforce of who can identify the population who is negative, who lives here, and is then talking about prevention.
I think I just want to add that we are transitioning, I think, our service model from PrEP as a secondary option to if you test HIV negative, like PrEP is for you. PrEP is for you right now. Yeah. I think routine testing, of course, is important, but I think that where we are with medication, it's almost ridiculous that every 3 to 6 months, you're hoping for the best. Or we expect people to come in and just, okay, you're negative today, great, we'll see you in 3 to 6 months, and we're gonna hope that you're negative next time. That's craziness. So I think we're just transitioning into, okay, you're HIV negative today, how can we get you onto PrEP as quickly as possible so that we keep you HIV negative, to your point earlier.
Absolutely, and I think I want to actually come back to you, Carl, and we've tooted around this uncertainty, especially in the policy space, the funding uncertainties, et cetera, but the ACA coverage requirement of preventive services that you mentioned earlier, including PrEP, it's under attack. And we have to recognize that, and that's certainly being highlighted, as heard recently by the US Supreme Court. And can you tell us how these oral arguments have gone or is about to go, and what are the next steps expected? Paint the policy picture for us.
Yeah, so I'm pretty good at policy. I'm not a lawyer though, and but I'll do my best. So some religious conservative groups out of Texas challenged the ACA yet again. And this time they went after the coverage of preventive services with an eye on PrEP, and saying it promotes, homosexual activity, promotes sex out of marriage, et cetera. So it's gone up to the Supreme Court, and the arguments were last week, and the mention of preventive services hardly came up. And only HIV came up once. One justice said, gave an example of providing AIDS drugs to people. But it really centered on the constitutionality, which is what the Supreme Court does focus on, of the appointments clause, of the power of the U.S. Preventive Service Task Force, and the body that makes these independent decisions and looking at the science of preventive services, and their power over to require insurers to cover them. And so it has to do with the appointments clause. And fortunately, the last administration sided with the constitutionality and said that of the coverage requirements. Surprisingly, pleasantly surprised, the Trump administration continued to side and protect the coverage of the ACA preventive services. We thought, given that it's the ACA, that they would not side with us. But they did, and they argued the case, and they said the Secretary does have power over the appointment of who's on the U.S. Preventive Service Task Force. The Secretary does have power to whether to accept them or not, and to make sure that insurers cover them or not. And so the oral arguments were not this past Friday, the Friday before, last Monday, a week ago, wow. And they seemed, I guess, to go pretty well, people thought. And that there were, as I said, the debate was not over coverage of preventive services. It was about the appointments clause and the constitutionality. So people thought it went well. And then on Friday, there was a request of both parties to provide additional briefs on what by law is there a requirement that the Secretary can appoint the members of the U.S. Preventive Service Task Force, was the question. And so that kind of maybe murky up some things. It may bring the case back to the lower court, we don't know. But those briefs are due May 5th, and we expect a decision in June on this issue. So cross your fingers, and it may be remanded back to a lower court. But so far, even though this has gone through different rulings in different courts, it's still the law of the land. Insurers have to provide no-cost preventive services today and until we hear otherwise.
That's great to hear, and I'm sure we will be keeping up with all those things in the next couple of weeks. But just want to flag for the audience, we're close to transitioning to the Q&A portion, so please start thinking about those questions that you have for our wonderful panelists. And my last question is going to go out to all of you all. And as we look at advancing policy-driven solutions, What specific policy innovations do you believe are most critical to overcoming some of these barriers that we've talked today? And how can we ensure that these policies are implemented equitably across the different communities? And why don't we start with Christian?
Well, first, funding, of course, right? We need to keep our doors open. We need to keep being able to do outreach, to do testing, to bring PrEP to community and to do education. I mean, we can't do that if we don't have any funding. I'm sorry, can you repeat the first part of your question?
Yeah, so just like specific policy changes or innovations that you are seeing from your research hat and community engagement hat in order to overcome some of the barriers that we talked today.
Yeah, I also think about how some of those barriers are so intersectional. People are dealing with so many different things, so we'll need intersectional solutions as well. So I think about like my interactions with people who use injection drugs or people who are unhoused. When we explain what PrEP is, they're like, I think this is a great opportunity for me. I would love to do this, but I don't have a phone. So how am I going to know when my next appointment is? Or I'm not stably housed, so I don't know where I will be. I don't know if it'll be convenient for me to attend those medical visits and things like that. So I think the medication is not enough. I think you have to have policy solutions that address really people's unmet needs, right? Because if you're competing for needs, housing, food, daycare, whatever, it's just gonna fall down people's priority list. So we're gonna have to address all of those needs. Thank you.
Dr. Rawlings?
So I would say three things to that. One, I would highly recommend that there be some changes at the state level about the availability of PrEP specifically within the context of pharmacies. That's a licensure issue, not a regulatory issue at the state level. The second one would be the ability to discern when you are trying to pick your insurance plan, whether or not this is something that the insurance company actually provides, which is obscure in many cases or not even stated at all, as a way that you, from a policy standpoint, can do this. And from an institutional standpoint, I learned a long time ago that if you want anything done, you should measure it. To know that you're actually accomplishing it. So whether or not this is in the context of Joint Commission or anything else that is doing the evaluatory component of institutions who provide health care, whether that's federally qualified health centers, hospitals, or other entities, that become a form of a measured and critical marker that becomes part of that particular evaluatory process. Those three things on a policy level, I would suggest would probably double, at the very least, the accessibility of PrEP in most institutions. Because if the provider knows that this is something they're going to be measured on, they'll do it. If the pharmacy is able to provide it, they can provide it. And if you are doing this in the context of being able to measure this, this is also going to be significantly important. I guess the last thing for me is my other big concern is we are breaking the infrastructure to measure how successful we are. The surveillance, the evaluation of what we're doing is being destroyed at both the federal and at the state and local level. So that even if we put all these things in place, we may be in a position where we can't tell if we're getting better, and we can just continue to have this argument in a vacuum.
I have a long list,
right.
but I'm going to agree with Christian. Funding is very, very important, and right now, programs are being cut, and one of the and staff is being let go, and one of the real dangerous things is anything focused on DEI is, cut. And so, and I think, Christian, you could attest to this, that us helping us, that they've been impacted. But anything, that focuses on Black gay men who need PrEP, or any, and of course, anything connected to trans community is gone. And so, how are we going to focus on disparities in healthcare, and specifically in HIV, if you don't focus on the communities that are most impacted?
Right.
So we've got to win that fight. We also have to focus on the uninsured. And, it's one thing to have payers for PrEP, but what about all those people who don't have insurance? And that's where we need the government to step in as well. And then, you know, on the people that do have insurance, to make sure that the U.S. Preventive Service Task Force recommendations, you know, that coverage requirement still stands, but also as we have new PrEP on the horizon, that insurers are required to cover that as well.
Absolutely. All right, so we'll officially move on to the Q&A portion. So there's 2 mics, one on each side of the room. So if you have a question, this is the time. All right, we'll start right here to my right.
Hey folks, thank you so much for this discussion. It's been really helpful. My name is Simon. I work for the American Medical Association. I do have maybe a couple of quick context points to share with y'all before getting into it, but in general, my perception is that this current federal administration has been gutting the CDC, specifically offices for HIV prevention, and that programmatic funding is essentially dwindling. If grants haven't already received a stop order, it feels impending, right? My experience as a public health practitioner working at different health departments, jurisdictions, is that prevention really heavily relies upon this federal funding. I've specifically worked on a few CDC grants where we help these clinics keep their doors open, right? So I guess my question, and it's also informed by my experience as a consumer, is how much of the policy and advocacy agenda can pivot to focus on pharmaceutical and insurance industries, knowing that they still have a pretty sizable margin when it comes to HIV prevention drugs. You know, I think the health equity mindset that I have is that, you know, we do rely on feds a lot for funding for these programs, but how much can we push pharmaceutical companies, for example, to lower cost of HIV treatment and prevention? How much can we push insurance companies to provide more comprehensive coverage? I have pretty good health insurance, and in order to get injectable PrEP, I still get...
Just speak loud.
I still have a balance of $800 after insurance kicks in. So I guess my question is, how much leeway do we have to pressure pharma and insurance companies to fill the gap? To fill that gap.
So I'll take a shot at that one. I think that there are 2 sides to that equation. One is for the treatment side. That is mostly, I think, where your discussion is about where pharma comes into this conversation. As far as I'm aware, there are very few programs that actually pay for preventative drugs in the HIV space. That's not if anything, that's actually pharma sort of producing that. The fact that first of all, there are only 3 drugs currently approved in the world for HIV prevention. One of them is generic. The other 2 are still in a branded context, and they will likely, the other oral medication will go generic relatively soon, and then there's a long-acting injectable, and there's another long-acting injectable that's coming forward. That process is a different question around how do you deal with the issues of treatment, because that's a different scenario. The bigger one is, I think, in many ways, it's not to let pharma off the hook, but the bigger place is the insurance industry, of what they will cover as opposed to what they are willing to pay for in this context. Another portion of that may become a point in the not too distant future is that what used to be a program to help offset the cost of drugs that were very expensive, the federal 340B program has also now morphed into this thing that now stops focusing on just individuals who have reduced access and limited means into a way by which hospitals and other payers are able to charge more on the premise that if you have one entity that does this, that takes care of poor people, we'll apply it to everybody else. That's a different argument that we can talk about separately, but the ability to get it covered is still predicated on the idea that you first have to get tested. So you get none of these drugs if you don't have a test that justifies whether or not you should get treatment or prevention. So I think we should, pharma wants to know both of those questions now. It used to be they only cared if you were positive. Now they also care if you were negative. And I think that that's a different conversation about what you're describing.
So if you're being charged $800 for your long-acting PrEP, we need to talk, okay?
Yeah.
I'll help you. You shouldn't be.
Great, and we have 3 questions, so I want us to get them to all, so let's keep the question and the answer short, but go ahead, sir, over here.
I'll be as brief as possible. Dr. Ray Serrano, Research and Policy Director with the League of United Latin American Citizens. We're the largest and oldest Latino civil rights organization, second only to NAACP. My question is, I guess on the issue, I heard a lot of discussion, and Latinos, we make up 19% of the population, but we make up 33% of the new infections. And I always think we couldn't have, the finding that we saw last year, the report of 33% new infections, couldn't have come at a worse time. Because when you have this administration coming in, and I say the biggest victim in this 4 years is Latino trust in the system. When you talk about DHS collaborating with IRS on ITIN numbers, when you talk about raids in schools, raids in churches, canceling Cinco de Mayo festivals, canceling Easter celebrations because people are in fear of immigration, it just seems very frustrating, very dismal, and for a population that so badly needs it. That, given the fact that Latinos, we are 40 to 45% of the uninsured population in the U.S. When LULAC, when we have health fairs around the country, we have sometimes 8,000 to 10,000 people coming to our health fairs because they have nowhere else to get screened. We offer free haircuts for the kids and tell them to bring their aunts and uncles and everybody else, and we get them screened for diabetes or whatever, but that's the only time that they have access to a healthcare system. And I guess my question is, we know the federal government is just cutting programs, gutting the CDC. What else can we look at? I mean, we could say states, look at the states, but like Florida, I mean, what are they gonna do? What other non-federal, non-state, or at least non-red state actors can we look at to combat this rising tide for this very vulnerable population?
Well, I agree, and I feel yeah. It is a bad, time right now, and people are hurting, and they're going to continue to hurt. But we have to fight. We have to fight back. We have to speak up. But in the meantime, that's where you rely on other payers. People who have insurance. So whether it's Medicaid, Medicare, private insurance. But there's also, programs for the uninsured as well in this country, utilizing community health centers, and also the 340B program as well, that clinics can use that money and should be using that money to help the people who are uninsured.
Hello, I'm Valerie Rochester, and I'm the incoming executive director of the Women's Collective based here in Washington, D.C. I start on Monday, and I'm scared. I'm scared.
Yes.
The funding situation is something that is, of course, a concern for so many, especially as we thought that ending the HIV epidemic initiative was going to be protected because it was one of the previous Trump administration's priorities. And now we're seeing everything being gutted as we continue along this process. But I was wondering, I haven't heard any discussion about status neutral, and I'm just wondering if that is a viable strategy for some of the things that we've been talking about, that whole person approach and making sure that we address everything that's surrounding a person in their communities and making sure that they receive what they need. As far as adopting that as a standard of care for people living with HIV and actually for anyone really, is that a viable strategy as far as helping to address some of these things that we've been talking about or we've been hearing you talk about today?
Yeah, I can speak to that a bit. We're definitely incorporating status neutral in our approach to care. I think going back to everyone needs to take an HIV test. So if you test negative, we're trying to link you into PrEP care, and if you test positive, we're trying to immediately link you into antiretroviral therapy. I mean, I think it's critical. I think that the idea that only people who are living with HIV, need HIV services is outdated. So I think status neutral is critical to the fight against it, absolutely.
The one thing I would add to that is it is a misnomer, and it's actually flat out wrong, that the majority of the people living with HIV in the United States are poor. That's not true. It's never been true. Also, it's a misnomer to believe that it's mostly poor people who are getting PrEP. That's not true either. It also is the fact that even though Black and Hispanic individuals make up 70% of the new infections, whites make up 25% of the new infections, the white population gets 70% of the PrEP care. This isn't about poverty. This isn't about lack of resources. This is also about who goes in and feels comfortable being able to have a conversation with their healthcare provider to actually get services. And I will argue that the group that is going to be the most impactful, I believe, around getting people into HIV care, in particularly the communities that we're talking about, are going to be those of us who are insured, because if we start asking the question about why aren't you doing, they will provide the services. The other one is that this is going to become, unfortunately, like a lot of things in the Black and brown community, this is going to fall mainly on women. Black women and brown women make up the preponderance of new infections amongst women in the United States, many of whom are insured. And what I've said in many cases, if you took all the insured women and started asking the question of why aren't you doing HIV testing in your practice, there's not a single provider in the country that is not going to start to wonder why they're not doing it, because if you leave and go someplace else, that's an economic hit to them. So I think that sometimes we get lost in the idea that this is only about people who don't have resources. It's about the behavior of those of us who do have resources and do have access to change the behavior of the systems in which we consume. If we can shut down Target because you don't like how much somebody's paying for whatever, you can sure as hell make an insurance company and or a provider pool decide about who they test if you stop this, if you say, I won't keep going to you.
Well, I definitely heard trust Black and brown women, but we're tired too. But the fight keeps on, and I have been giving the thumb, so we have to end the session. I'm so sorry for the remaining questions. Myself and the other panelists, we're here for the remainder of the day as well. As you see us, please come talk to us, and thank you all for your attention to this critical topic.
Thank you.
Thank you.